I'm George Williams. I'm the Secretary for Federal Affairs. And our closing session today will be the IRIS Registry and its impact. It's more than just a penalty. And I think you're going to hear some really amazing facts about the IRIS Registry today and how physicians are able to incorporate this into their practice. Before we begin, I'd like to thank our colleagues and strong supporters from Genentech for their help. We have with us today Alana Paul, Public Policy Manager, Christopher Sims, Marketing Director, and a good past friend and current friend of the Academy, Allison Neves, Senior Manager, External Communications. So thank you all for your support. And we've assembled a great team to discuss with you how IRIS is going to change your lives. First of all, we have Timothy Parr, Vice President, Technology at FigMD, Aaron Weingeist, Director of the Leadership Program. He'll be sharing his experience, how he's incorporated this into his clinical practice. And then our Senior Secretary for Ophthalmic Practice, Bob Wiggins. Additionally, we have a surprise guest, and that is the president and founder of FigMD, Senkat Barale. Senkat, welcome. We're glad you could spend a little time with us. So what we're going to do is present to you how the IRIS Registry works, and then we're going to talk a little bit about how some of us have incorporated it into our clinical practice, and then we would like to really open it up for discussion. Because I think once you start to see the power and the potential in this technology, you're all going to have great ideas on how you can incorporate it into your practice. So our first speaker will be Mr. Parr. He's going to speak, since this will be a live presentation showing exactly how the website works and how you can access your data. So Tim will be speaking from the table.
Thank you, Dr. Williams. Okay. Make sure this is everyone here okay? All right, so many of you are already familiar with the registry dashboard and how it works, so we'll just touch on a couple of features, but primarily what I want to show you is the new and upcoming analytics module and some of its capabilities and how you may be able to use that within your particular practice. So here's the dashboard, and for those of you who have not seen this, this shows you a listing of all of the various measures that have been defined by IRIS, and how we can how you can access to see your group's performance on those. Any of these particular measures you can drill down to get a detailed view. On the left-hand side, you see a rolling 4-quarter trend graph of the data, and how, in this case, we're looking at the group as a whole, how it can be, how you're performing compared to the blue line, which is the registry benchmark or registry average. The registry average is just that. It is the average performance of all of the other participants within the IRIS registry. So, and on the right-hand side, we see the same information, but you break it down into a tabular view where you're able to see the actual numerator and denominator numbers of those patients that make up this performance number. So in here, in this case, all would represent the total number of patients that had qualified to meet a particular measure. In this case, we're looking at IRIS 4. The plus column represents the total number of patients that did actually meet the measure for that quarter, and then the minus column would represent the total number that did not meet that measure. And that is how your performance percentage is calculated. Additionally, you can click on any one of these blue numbers. So let's say we wanted to see the 135 patients that did not meet this particular measure. You could click on that and drill down. And this is a demo version, of course, so this information has been de-identified. But there you would be able to see the actual patient name, their medical record number, gender, and date of birth. And only you or people within your practice would be able to see that level of detail. So moving on to the analytics piece, which is of great interest to many people. Analytics really, if you think of it as a way to ask questions of your data beyond the measures that have been defined by the IRIS registry. Often we get people who say, well, the measures are great, but can I write my own measures? This is really a way for you to do that. It's also a way for you to be able to identify subsets of your patient population, whether it's based on a particular performance or a medication that they may be on, a particular procedure or disease condition or whatever that case may be. So just an example here, I want to show you, we're looking at age-related macular degeneration. So we're looking at the years, and we're also looking at all the months within that year. And we're looking at our total cataract surgery count. And of those patients who had yes macular degeneration or no macular degeneration on this side. And then we're sorting by gender. And so this gives you some detailed numbers here. And again, like before, any of these numbers, if you want to see those 30 female patients that did have macular degeneration, we can click and get that list, and then you can export that out into various file formats such as Excel or as a PDF, etc. So let's say we want to modify this particular report. There's a fields list that's available. And in here, you can select from any one of these. Now, this is a sample of the fields. Your EMR will vary as to how the types of data elements that are available. But let's just say we're curious as to how many of those patients had post-cataract surgery major complications. So we can drag that over either here in the form and drop it, or over here in any of these columns. So let's just say we want to drop it in right there. The little plus sign refreshes. And now we can see that we have updated our list, and now we have the category to sort by those patients that did and did not have the cataract surgery complications. The graphing at the bottom is also helpful. Many people had requested they'd like the ability to be able to graph this. So as you can see from this list, we have a huge number of types of graphing that's capable. So let's say we wanted just a basic bar chart and we wanted to add the labels. This just gives you an example of some of that capability and how you can see the comparison of those that did and did not have that. So you can build your own use cases in here. You can start with a clean slate. There are going to be several standard use cases that will be distributed by the Academy. And then this can also be shared. If you have a single person that creates these and wants to export or share it with others within their practice, you can do so. All right, so at this point, I'm going to stop and take any questions that you may have. I think the questions are in general about the IRIS registry, not just the dashboard.
Opportunity to drill down on some more,
Yeah.
just a little bit. Well, thank you, Tim. That's terrific.
Okay.
So I'd like to share with you my personal and our practices experience on how we've been able to use the IRIS registry in an attempt to improve our practice quality. So what we're really talking about is, as you just saw, the power of the dashboard to look at individual groups of patients, to look at individual patients, to analyze by disease state, to look at surgical results, and the power becomes increasingly apparent the more time you play around with this. And what it's going to allow us to do, I happen to practice in a large group, so we're going to be able to compare physician to physician. We're going to be able to look at a variety of disease states. So this is just one example. Now, this is not our practice, but rather these are the codes for the repair of retinal detachment. So this is more of a big data approach, but you can see the power here. We have data now in IRIS on 12,581 patients that have undergone vitrectomy for retinal detachment. We can compare that to the number of scleral buckles, which is 67107, and we see that only about 2,700 of patients with retinal detachment receive scleral buckles. So this will allow us to analyze practice trends, but importantly, it's also going to allow us to analyze surgical results. So the bane of the retina surgeon's existence is the return to the OR. We all take that personally. Things did not go the way we wanted it to. And so we can now look by code and look at our return to the OR rate within 90 days. Now we can do a lot of other things here. We could look at what our postoperative vision is, what additional procedures were performed within that time. And you can see that after a scleral buckle, for example, in this data set, we're doing pretty well, only a 2% return to the OR. But as we get into the more complicated retinal detachments, 6, 7, 1, 1, 3, you can see that our return to the operating room is around 30%. And as a practicing retina surgeon, I can tell you those are pretty realistic numbers. And if you look at the data that's reported on our success, our one-time surgical success for complex retinal detachment, it's probably in that 60, 70, 75% range. So I think that gives you a feeling for the power to look at big data trends. But as you just heard, we can also now, within our practice, look at our performance by physician, by location. We can look at the practice as a whole, and it's going to allow us to compare ourselves to national benchmarks. So this is just a screenshot of my practice. Here we can see the various measures that we look at, and I know it's kind of hard for some of you to see in the back. But as Tim just showed you, we can track trends on a quarterly basis to see how our performance is improving. We can look at the number of patients that are eligible for these various measures and see how we're performing. And then we can see if we're getting better or getting worse. So we have a monthly meeting with our account manager at FigMD in which we go over this data. We look and he tries to identify for us where we're not performing as well as we should. And then we can take that information back to my partners and say, this is where we need to do a better job. So now what I'd like to do is ask Tim to take over, and he's actually going to pull up my practice's data. There we go. So the first slide here you're going to see is, and this is in real time. So these are all the measures that are available that our practice uses. So green is good, we're doing okay. Red is bad, it means we're outside a 10% range. And yellow, we're kind of doing okay, but we can obviously improve. So now we're going to go to 4 of the more common ones that we look at. And you can see here, again, I know it's hard to read. The top is diabetic retinopathy, documentation of macular edema. Beneath that is communication with the primary physician. So you can see we're not doing really as good a job as we should be in that particular category, but in the others we seem to be doing all right. The 2 bottom ones are two new measures that the Academy just got in, and that's exudative age-related AMD with loss of visual acuity. Remember, we can measure visual acuity now. We're just not checking boxes. We can actually determine what impact our therapies are having on patients. And here we see the one below, QIM14, is diabetic macular edema, loss of visual acuity. So this is across our entire group. And then we can say, all right, why are we, under measure 3, why are we not where we need to be? So then we can look at individuals. Before that, we can track our progress over time in that. You can see that we were actually worse, and now we're picking it up. You can see as the curves converge, blue is the benchmark, gray is our performance. And so we actually are getting better. So this gives us actionable information. It changes our performance. Next. So those are the 4, and now we can drill down and we can try and find out who the knucklehead is that's holding us back. And there he is. So as I look at my performance, and this is as of today, as of right now, I can see that I'm doing okay on measure 2. I'm not doing very well on communicating. I got to think my wife had something to do with this. But it's a common criticism that I've been given. In any event, I need to do a better job. I must become a better communicator to the people that are sending patients to me. And you can see that I'm doing okay in some of the other categories. But that's the beauty of this, is that we can look at individual performance, we can look at practice performance, we can track our trends, and not only can we find out when we're doing better, we can find out when we're doing worse. I've had the experience over the years of people calling me up and saying, you know, I never get letters from you guys anymore. And, you know, sometimes we take our referral doctors for granted. And so I think it is apparent just how you're going to be able to use this data to change the way you practice. And I really believe it's going to make us all better doctors. Thank you. All righty. So with that, I'm going to ask Aaron to come up, and he's going to discuss his experience with Iris.
Good afternoon. I'm Aaron Weingeist. I'm the director of the Leadership Development Program and also a private practice ophthalmologist practicing comprehensive ophthalmology in Seattle. And I'm going to talk about my experience. We have Allscripts as our practice management software, MedFlow for EHR. We've been on these systems for the better part of 3 years, and we started with Iris about 1.5 years ago. I have no disclosures. This is my dashboard as of the end of March, and like George, there's some areas that we do well in, and there's some areas that we don't do so well in. It's interesting to show that my diabetic eye exam numbers are low, and that my complication rates within 30 days after cataract surgery are marginal. And those are, of course, things that we want to improve on. The level, when drilling down on Iris 2, you can see that my trend over the last year, and there's been a concerted effort to improve the way that I document. I think we all think that we're providing good care and doing all the things that we're supposed to do with patients, but when you're able to go back and look, sometimes what you discover is that the things that you think you're doing are not really documented very well. So a concerted effort to improve on the way that we document has been very helpful for me and for the guys in my practice. You can see the numbers and the way things have improved over the course of the last year. I am communicating a little better than George, but that's probably all that I'm doing better than George. Again, this is in Iris 3. And so for me, Iris has really allowed me to monitor my PQRS measures and do a good job. It has helped me ensure that I get to the areas that look like they need improvement so I can provide better care to my patients, document better, and hopefully preserve my ability to access the plans that I need. It does allow me to be in a little bit of competition with my partners to help poke at them to try and do a better job. Some of us are competitive, and that can be helpful. And in our group, we were approached by our community hospital and asked whether we could demonstrate that we were providing good quality care to our patients. And Iris was a simple way to go back to our department chair and say, you know, we're already involved in a data registry, and do we need to provide any other measures of quality other than the registry? And they came back and said no, so we're able to use our participation in Iris to demonstrate quality at the hospital. So it also helps keep us on top of attestation and on a quarterly basis so that we can have an idea about at the end of the year whether we're going to be able to attest, and helps us improve along the way. Limitations that I list here are really related to March, and things have changed a little bit, but I use mostly I codes, and the diabetes code was mostly designed to capture E&M codes, and so part of that red bar that was there was related to my use of eye coats. And the complications after cataract surgery used to include intravitreal injections in the 90-day postoperative period after cataract surgery as a surgical complication. And as of the data that I looked at earlier today, those have both improved. So am I providing better quality care? I guess I'd like to think so. At the very least, I'm going back and making sure that the things that I talk about with patients that I'm documenting in a way that have some meaning for people when they audit my charts. And I think that IRIS has been a big help. I would second what George said, but also add that it's been very helpful with our hospital and being able to demonstrate quality without having to go and create a whole new quality plan and work group or something. So, thank you.
And our last speaker before we open it up to questions is Bob Wiggins. Bob will be discussing a summary of physicians' ability to use the IRIS registry.
Okay, there it is. Good afternoon. So I'm going to look at IRIS a little bit through the perspective of practice management. So we ask, who doesn't want quality? Well, we all want quality. The patients want it, physicians want it, government wants it, our payers want it. So why is everybody grumbling about improving quality? Well, it's not improving quality, it's reporting on quality that's causing all the grumbling. And this is a study you heard about in the session yesterday afternoon, just published in Health Affairs, that gets to this issue about the fact that they looked across a broad range of specialties and found that staff and physicians were spending on average 15 hours a week reporting on these measures. And it's not just the ones we think about, PQRS and EHR meaningful use, but other payers have multiple measures. Hospital systems have measures that doctors are reporting on, and there are hundreds and hundreds of these measures out there that physicians are reporting on that aren't terribly well coordinated between these different groups. And it turned out that they estimated about $15 billion annually was spent on reporting on these quality measures, worked out to about $40,000 per FTE physician. And over 80% of physicians in this study said in the last few years they are reporting on even more quality measures, and yet less than 30% felt it was actually improving the quality of care. So, toll on time and money there. The next one is the emotional toll on physicians. This was also alluded to yesterday. All of the extra documentation that's required with our electronic health records, including reporting on quality, has been attributed to leading to burnout. And if you look at some of the top areas on the list here from this survey as what's contributing to burnout, a lot of these can be directly attributed to our computers and all of the documentation that's required. And then finally, if that weren't enough, because of all the extra documentation required, and I've just talked to several of you this morning that are just converting to electronic health records about how you've had to cut back your schedule and patient complaints are going up and wait times are going up. Well, wait time is negatively correlated, as you might imagine, with physician scores on the CAHPS survey, but it taints the whole picture of quality of care that the patient is experiencing. So when they report on the quality of information that the doctor provided or the staff provided, or the instructions that were provided, or the overall experience of their care, long wait times correlated with negative scores on all of these measures. So the very thing we're trying to improve quality is actually a detriment to quality from the eyes of the patient. And so I'm going to go through you and just show you really how marvelous an innovation IRIS has been in our practice, and just take you back through our history of quality reporting. We've been reporting our practice, Asheville Eye Associates, from the very beginning. It used to be called PQRI and it's now PQRS. But there were 3 measures to report on, and these were, what people say the good old days, paper, right? So we had our electronic health record, but we were reporting all this on paper on our claims forms, and we'd ask the technician at the end of the exam to make sure you circle those codes at the end of the exam that we actually completed these measures. And so down there at the bottom, you can see where they've circled. And these were our results. So in the first year, that's all we had to do was circle the chart that we did it, or that we didn't do it. We just had to make a circle. About half of our physicians qualified for the payment. And then you look in 2008, and 1 out of 14 physicians qualified with this process. And you say, talk about knuckleheads. They said, Wiggins, what is going on, with this? We got 50% this year, and we only got 1 the next year. And the reason being, if you recall, is you didn't get your report on how you did in the first year until well into the second year of reporting. And so by the time we got 2007's report, we were almost through 2008. So talk about anything but real time. This is not real time data we were getting. So by the end of 2008, we figured, no, we've got a problem here. So in 2009, we saw the lousy results from 2008. You can see by 2010, we finally had this paper process figured out. 4 years. So the next phase was an improvement. We were now filing electronically through claims, and our vendor was helpful, and they now had highlighted in yellow, okay, you've got a PQRS measure here, so you better pay attention to this one. So that was an improvement over the paper where we didn't have that visual reminder. But then, as you can see, there were 9 clicks you had to go through. And remember, you had 3 quality measures then. So 9 clicks to finally get through and document that you had met this measure. And you can see this was highly successful. We were 100%. I can tell you, though, when our administrator and I presented this data year by year and the dollars we had gotten in incentive payments, if the physicians had had any tomatoes in the room, they would have all been aimed directly at the 2 of us. And they say, what are you talking about? This is a success. This has been absolutely horrible. It's terribly impacted workflow. Our patients are waiting longer. Everybody's unhappy. The 9 clicks to get through every one of these measures, we just as soon forget PQRS, even though we're meeting all the measures. And so then, help finally on the way. By 2014, we'd come on with IRIS and have been using this to report on these quality measures for the last 2 years. And as you can see, once the mapping is done, there's a little bit of time involved on the front end, but less so the more people that are using your vendor come on. Your time for reporting goes down to 0. And the grumbling goes down. In fact, I think our physicians have even forgotten these programs are out there because they just don't see them anymore. It's all happening in the background in terms of what they have to do to report. And so here we are. As George mentioned, you can get real-time data, so 100% success rate. And if you know a little bit about me, you know I'm a big believer in lean healthcare, and you want to talk about taking lean healthcare to the max, taking these horrible processes that we've had in place and converting it to something where the physicians and staff no longer even recognize that this data is being collected. And so to get back to quality, we all know we have to have the data to improve quality. What gets improved is what's measured. And Dr. Weinstein has said here that we know more about what's in a cereal box than what's in our healthcare system. And we're collecting the data to help us improve that quality. So what's the IRIS registry about? It's working on measures that directly contribute to patient care. a way that doesn't impact workflow, and which leads to improved patient and doctor satisfaction. And IRIS is actually already measuring patient satisfaction, reporting on the cataract measures, and we're looking at ways to do that. Depending on what happens with MIPS and what they're looking for on quality reporting, it's something we're looking at that IRIS could report on that as well. So where are we now? We're just in the process of mapping the new subspecialty data measures in the practice. I'm particularly interested in doing pediatrics at the pediatric measures. These are developed in conjunction with the subspecialty societies. So we have two pediatric measures here. I'm very interested in seeing what's going to come of this. I've had a little preview in participating with the Part 4 of MOC, the Quality Improvement section, and I chose amblyopia as the measure. As you know, if you've done it, it's a fairly tedious process, and the ABO is working on streamlining that, and in fact, working with IRIS. And I can tell you from that little insight into my data, and I was having to look for just a few charts to get follow-up on, and how many charts I had to go through to find patients that actually returned enough for follow-up to include them in the data set. It's amazing how many numbers of patients had not shown for follow-up or dropped out of the system, and I think we're going to see this very easily with IRIS. You'll notice these are also looking more at outcome rather than process measures, and that's intentional. Process measures tend to be met fairly easily. Outcomes take a little bit longer. And then finally, I read something coming up here, an email that said that something to the effect of that we are the lost generation of physicians, that we're doing all this work, all this massive change that's going on just so we can benefit the next generation of physicians that's going into healthcare to work out all the kinks. Well, I don't think it's all that bleak. I see the glass as more than half full here, and I really see, just like we were shown here, that we're going to have this data at our fingertips, not just from IRIS, but from our EHR and from our practice management system. And I think we're going to have this dashboard that we can go to and get real-time data. How many patients did we see in the clinic that day? What's our days and AR doing? What's our efficiency? We're going to be able to look right away and say, what was the average wait time by doctor in the clinic that day? What are our patient satisfaction scores for that day? And then IRIS inputting data on quality metrics and then cost, as Bill alluded to yesterday, looking at bundles of care. So I think it's an exciting time to be in medicine. Thanks.
Okay, so we would like to hear from you. Questions, comments? Anyone else can share their experience with us? While folks are... Yes, please.
Hi, I'm Chastity Singleton. I'm in Nashville, and I'm at an academic institution, but in this multi-specialty group, there are a lot of patients. I'm comprehensive, and there are a lot of patients that come to me for cataract surgery, for example, that have multiple ocular comorbidities, and I'm wondering how the IRIS registry, for example, the data that was shown for vision better than 20/40 after cataract surgery, but they have severe glaucoma or they have some retina problem that limits that ability to get to that level. Is there some way to designate through IRIS for those type of conditions, and also for the return to surgery? Maybe there's either a plan to return to surgery by another specialist in the group, or after retina or glaucoma surgery, they develop a severe cataract that needs to be done within 90 days post-operative. Just how does the system delineate?
So the short answer is yes, you will be able to do that, and you'll actually be able to go back and look at the reasons. Hopefully you're just going to have a handful of patients that had to go back to the OR. And you'll be able to specifically pull up that patient, that individual patient, just the way Tim was showing you. So you'll identify your criteria, you'll put that in, it'll give you a list of those 5 patients that had a problem over the last year, and you'll be able to drill down into their medical record and find out exactly what happened to each of those.
So as it reports quality, does that suggest that our quality is less for those indicators?
So that's really a measure question. And so the Academy has been working with a variety of agencies, including CMS, to come up with appropriate quality measurements. If the numbers are big enough, issues, we all sort of think that we're seeing the sickest patients, and many of us are seeing very sick patients. If the numbers get big enough, then we're going to be able to say across a large population what the percentage of patients, regardless of their underlying disease processes, should end up at 20/40 or better. But again, they're benchmarks, they're not absolutes. And I think we're all going to be learning as we go forward how to evaluate this data.
Thank you.
Anyone else have a comment on that?
Hi, Suzanne Everhart. Much like Aaron, I have the same system, Allscripts and Medflow, and I was interested in the technology and what's available now in terms of interfacing. What work has to go forth for the new measures to map Medflow to IRIS Registry? Is that something that's interfaced with Medflow?
Well, I will ask the gentleman who built the system. Senkat, would you like to take that one?
He's gonna let me do that one here.
Alrighty.
So the good news is we've already worked with both of those systems, and so we already have that process worked out. There are no real interfaces that are required. We just need read-only access to the database, and that's something that we discuss with your IT staff or your vendor, whomever's involved at that level for your particular practice. As far as the mapping goes, a part of the implementation process for the IRIS Registry is that your site is assigned a client account manager from our company that works directly with whomever you designate in your group. And they work with you to understand where the providers are documenting this information in the system. And the nice thing is that we take into account how each provider is documenting. We are collecting structured as well as unstructured data. So even if it's in a physician note, for example, as long as we know that information is there and we work through that, then we can map to that and pick that up. And so we take the unique documentation styles of each provider into account so that you don't all have to be using a standard documentation method. Does that help answer?
That's helpful. And also, in follow-up, how do I actually see how I'm doing?
Well, through the dashboard. In the beginning, you'll be, either you or again, whoever you designate, you'll be receiving some reports to see how you're performing. And in the beginning, you'll notice many of the trends that we showed, the trend graphs, they had an upward slope to them. And that's because as we work with your practice to understand and find the data, that your performance continues to increase. Once you or you're in what we call maintenance or production, you'll have access to this dashboard. So every one of the participating providers within your group have access to this registry dashboard we've been showing you, as well as your administrative staff. Some groups, the docs like to look at this. Some, they just leave it to their administrators to view this and let them know how they're performing. But each one has that ability to see the breakdown of each measure and how you're performing and which patients are and are not meeting that particular measure.
And final question. Right now, I look at meaningful use, and Medflow reports my meaningful use requirements because that's what we're doing now. As we move to MIPS, is your map in IRIS Registry going to provide all of that information to see that we're meeting those standards? So according to our lecture yesterday, I think we are out a little bit on the ACOs and the APMs, but otherwise it should be able to do it all?
Yes, that's correct. The registry currently can perform either for PQS reporting or also what's known as QCDR, as a qualified clinical data registry to CMS. But as CMS evolves into whatever program, we know MIPS is coming down the road, and whatever programs, the goal is to have the registries adapt and morph to be able to continue to report to whatever the requirements are for CMS.
Okay, thank you.
You're welcome. Thank you.
Questions specifically about Medflow. We're currently in the process of doing that mapping that you talked about. And as you know, as as you come along a little bit later, that work will have been done by more and more people, and so there'll be less and less for you to do with your specific vendor as time goes by.
And just this week, David Park, Bill Rich, and Cherie McNett met with senior CMS officials, demonstrating to them the power of IRIS. And I think it's safe to say that they were impressed, and they see the potential here. As we discussed yesterday, theoretically, IRIS can give them everything they want to be able to track performance and improve value. I think George is first.
Yes, thank you, George. George Ellis from New Orleans. I have a comment and then a question. My comment is when Bill Rich introduced the IRIS registry to us several years ago, I could not get my head around what this was all about, and now I can see what a visionary he was, and I really appreciate all the work and effort that he put in and the Academy supported in this endeavor. It's been really going to be really helpful for a lot of us. Secondly, my question, Bob Wiggins just now and Michael Chang earlier today talked about some data. Michael's was a time motion study, and I've just heard some reports from the literature, and I'm having a little hard time trying to put all these little pieces together. I think, Bob, you said it was 15 hours a week of physician time for reporting these quality measures, and I heard Michael say that on his time motion study that physicians were spending 10 minutes with a patient, but also on the EMR part of it, it was the EMR documentation was taking 10 minutes a patient. And then I heard there was $40,000 a year per physician that was being spent on documentation, and I wasn't sure if that's physician time and how that relates to the 15 hours a week. And so is there some way to pull all this information into one easy to understand paragraph?
Yeah, most of that time in that slide is staff time entering the data, and a smaller portion is physician time, and likewise going along with the costs. So IRIS doesn't solve everything that we're doing, but I think I showed you it solves a big part of what we're doing, and I think, it's just going to be step by step. This is a quantum leap forward, though, as far as I'm concerned, in terms of improving workflow.
So if I understand, the 15 hours a week was mostly staff time?
It was mostly staff time.
And that's where the $40K a year came from?
Yes,
I
and
see.
a smaller portion was physician time.
Was physician time. And then, so Michael, I know you're in the audience. Can you justify those two times that you mentioned? One was the 10 minutes per patient that was taken up in documentation, and 10 minutes per patient that was taken up in examination room time?
No, George, thanks for citing that. So let me just sort of describe where these data came from and what they do and don't say. So this part one is 5 ophthalmologists, all at OHSU, Oregon Health and Science University Academic Medical Center. We built some iPad apps and then followed these people around for about a year and a half. When the attending physician was in the room with the patient. So are they documenting, are they examining the patient, or are they talking to the patient? 10 minutes per patient, interaction time between the ophthalmologist and the patient, so 400 patient exams. Of that time, 30% was documenting in the EHR. Okay, that's part one. Part two is how much time total are these attending physicians documenting? So not residents, not fellows, not staff, attendings. So we basically went back in the EHR audit log for every single doc at the medical center and figured out, when are they pointing and clicking? Like these EHRs document, they track every single mouse click and keystroke in an audit log. So for every patient, the attending physician is documenting 10 minutes is what we're seeing. And of that 10 minutes, some part occurs when they're in the room with the patient, some part occurs later in the day, some part occurs when they're at night. So that's where those figures
3
come
to
from.
4 minutes during the patient encounter, and then the additional 5 to 6, 7 minutes at another time.
Right.
Part, George, depends on, is the physician doing most of the data entry, or do you have a scribe doing the data entry? We use scribes in our practice, so when I was showing those 9 clicks, that was a scribe going through, and that was staff time there.
And I know that in some institutions, like at Oregon, there's residents and fellows that are entering as well. So it's a big hodgepodge, but it's a lot of good parameters that are helping us to try and understand this and the burnout question. So thank you.
Remember, when Iris is working, it's doing it when you're asleep. So it really is a very efficient way to gather this data. So Michael, you're building these apps yourself? Because I built some apps. Last one was for a credit card, but so it gives you a little feeling. We're all coming at this from a different perspective. Many of us are very IT savvy, many of us are not. And so the key to this technology, it's got to be seamless for us. And frankly, we're not there. There are still a few glitches. There are issues related to mapping. Some vendors are not as cooperative, I guess is probably the best word, as other vendors. But as you go forward and you start to consider information technology for your practices, this should probably be the second question you ask about any technology you're considering to acquire. The first will be the price. The second is, are you compatible with QCDRs? Front microphone.
Yeah, two questions. One, just following up to your comment. What is the most recent update on Epic connectivity?
Well, we have the most recent update. Kat, would you like to share what we talked about?
Sure. So I'm going to try to be as appropriate as possible in this update. So we are pursuing, with most vendors, we pursue a pathway of upfront engagement and giving them the opportunity to be, to be a partner in the conversation, while actually doing what we need to do and get the data out without them. The recent update with Epic is not a whole lot has changed in that we continue to have the ability to extract data from Epic without Epic, and we continue to have conversations with them to engage them, and that has been that way for years now. So that's basically what the update is. I'm sorry I couldn't tell you anything more encouraging.
Thank you. And then second question, there's a lot of concern among training centers that there's the potential for disincentivizing teachers of cataract surgery and other surgeries, given that complication rates will be accounted for. So what is the plan moving forward for teaching and training centers in this reporting?
Well, as someone who runs a residency and a fellowship, that's always a concern. I think that what we have to do to address the Epic issue, and I'm at an Epic-based institution, is we have to remember that we are the customer and that Epic works for us. And the problem we have is that ophthalmology is a relatively small player in most major medical centers. But I've certainly spoken with our IT people, with my bosses, about the importance of them of Epic being able to participate in this. And I'm going to dump it back to Singleton briefly. So you just told me that how many hundreds of thousands of potential doctors are now potentially enrolled in FIG-MD programs?
So if we count, okay, so here's how I would answer that question. So when we contracted with the AAO, that essentially opened up the possibility for the AAO membership to come on board. And I think you mentioned the number around there's about 18,000, correct? So if we take all of the contracted FIG-MD customers, at this point we're upwards of about 200,000 in terms of the potential. That's not 200,000 physicians on these registries, but that's the upper sort of potential as these registry programs escalate and become more robust. So
and how many did you have 2 years ago?
Pardon?
And what was that number 2 years ago?
It wasn't that. it was a lot lower than that. Yeah.
So I guess that my point is that the growth is astounding. And Epic or Cerner or the other big players are not going to be able to ignore this phenomenon. But we have to remember that we're the customers. And this is something that we need. It's good for patient care, it's good for physicians, and we simply can't take no for an answer any longer. Back microphone.
Yes, I'm interested in the panel's thoughts on successful communication about the dashboard in your practices, how it is that you're distributing dashboard information. Are you having each physician get a sign-on? We've done that. We've had some difficulties communicating about the dashboard because it's difficult to print the report. And I'm just interested also in whether or not you think it's leading to an evolution in your group of a physician quality leader, and whether or not you think that you have someone in your group that's taking that role on more because now we have data to look at.
Well, I'll share our experience. The first experience, whenever you're red or yellow, is the data's wrong. And certainly my data is consistent with the fact that I'm not performing where I need to. The data are what they are, but remember, the data are not infallible. So you want to make sure that the data are accurate. So for example, in our practice, we were underperforming on something that we all knew we were doing. And it turned out that it was a mapping issue with our vendor, identifying whether or not a letter was sent to the referring doctor. And once we were able to, again, working with FIG, to figure out what the issue was, then all of a sudden, we didn't change anything, but all of a sudden our numbers got better. So if the data doesn't make sense, don't just accept it on face value. If it doesn't make sense, question it. Try and find out why. We actually did an independent audit. We went through some of our charts just by hand, and we said, well, wait a minute, there it is. I said I sent the letter, and yet the mapping wasn't identifying that. But everyone, when they get a bad score, the immediate response is, well, something's wrong. Sometimes it is, but most of the time the data is accurate. And you have to look at that as the opportunity to get better. But I guess to directly answer your question, some of our guys are interested, some of them aren't. It's usually, if you're young, you want to go in and play around with it. If you're old, you don't play around with it. Bob, how's it working in your
I was
practice?
just going to say it's a good question, and currently what we're doing is reporting group metrics. Our board meetings are currently mostly all financial data, and this is going to change. We're going to be reporting that quality data as a part of our regular board reports. Currently what we're doing is going to those physicians in their clinics where they're not meeting the metrics to see what needs to be done to improve on those. But this is all going to change.
Is that George back there?
Ken
I'm sorry.
Ken Chang. So this question was asked years ago when the whole EHR phenomenon started building, and I guess I'm kind of dense and I'll ask it again, but especially now since Iris is picking up all of this information in an incredibly valuable manner from the back end of the engine, it would seem to make sense, and it would seem that you would get better data and a better research tool if, just like a clinical trial, the front end was the same from everybody. And is there any thought of building the front end of the engine so there isn't errors in mapping and interpretation of the data as you pick it off, and one person's interpretation of something? In other words, if everybody had the same type of EMR going into this would solve so many problems with connection between different offices, and it would solve a giant headache. That seems to be the elephant in the room.
I'm going to ask Dr. Rich to answer that question.
That would be the ideal world, and Mike Boland's up at the mic, and everyone wants to have a common data set. The big problem is getting the EHRs to adopt that data set, even if there was an easy way of sharing across platforms. We think that that's not going to happen on the regulatory side. That's going to happen on the client demand side. As we're starting to find out, Flora alum is in the back of the room. As people are starting to look at new systems, many practices, including mine, my partners here are listening to this, there's a secondary market now. So what we're doing is presenting our common data sets and said, will you adopt us in the EHR? They look at the market, this is an emergent market. I said, yeah. So the demand is going to come from the users, and I'm not very optimistic about the regulatory side. I'll make a brief comment about the big boys, Cerner and Epic. It's been frustrating working with Epic. There are no technology problems with this. However, I think we have a breakthrough, and in two places. Number one, the awarding of the Department of Defense contract to Cerner. The Department of Defense has a new subsidiary with an acronym that must have been done by the CIA. You can't figure out what it is. But their whole purpose is to develop comparative outcomes between all of their physicians in the Department of Defense system and their beneficiaries so they can compare and show Congress and the different branches of the service we're providing quality care. They basically told Cerner, this is going to happen with Iris and others. The second thing that's going to change a little bit is if there's a different demand on Epic centers for reporting of specialists. And pretty sure that's going to happen. We've had extensive discussions. This is being driven by the consumers, not us. Once that happens, and specialists, or academic centers, large groups of any kind, have to start reporting, they're going to be putting the pressure on Epic, which will be much more effective than the regulatory process through ONC. So I'm optimistic long-term about both Cerner first and then Epic.
And Congress is starting to listen. Now remember, we have the, what's the name of the act, Kathy? Yeah, basically the Interoperability Act. Congress has spent a lot of money to get us all to where we are. And when you explain that certain vendors are not playing ball with everybody, they're not happy. So one way or another, whether through the free market or through the legislature, I think it's going to get fixed. Yes?
Great. So I just wanted to address what I think is the ongoing sort of misunderstanding about Epic. There's been this problem, I think, since the beginning. First of all, we've had a method now for months of extracting data from Epic in a standardized way and shipping it to FIX. If you guys aren't aware of that, we need to chat. And second of all, I think as you're thinking about this, you got to think about, Epic doesn't control my data at Johns Hopkins, right? I control my data. So you're going to have to interact with the actual source of the data, which is all these academic medical centers. Not that that's any better than interacting with a large company, but all the data are controlled at the local place, not centrally. So if you're going to Epic to get data out of my institution, you're going to the wrong place. So I'm happy to talk with anybody about any of those pieces. But I'm surprised you're still claiming it's a problem because it has not been now for months. There's a published method we've been sharing it. Josh is working on it at Michigan. They're working on it at Pittsburgh. Other places for getting this stuff out. And you guys should be getting data already from some institutions. So that's a weird statement that I'm happy to talk to anybody about.
No, so we are getting data from Epic centers.
No. So again, right, from Epic sites, yes. Every site has the ability, whether it's a priority or not, and maybe it goes back to what Bill said, there's no real, we don't need the quality piece, right, in most of the large places. So whether it gets prioritized at the local place to turn on, separate question, right? But that's the fundamental issue. And then real quick on the interoperability piece, even if Congress does put something out, we need to be thinking as a specialty about how we are going to share our data, because you're going to get a standard that works great for internal medicine. We'll have blood pressure, height, and weight. But if we want our stuff to be transmittable and shared with each other, we're going to have to do work as an organization to make that happen, as a second comment. But I'm happy to talk to Fig again about Epic, because I think there's still a misunderstanding that I'm happy to help address.
You might want to read your Epic contract, a little more detail.
No, so there's nothing in there that I can't share data with anybody I want to.
You might want to read it again.
I swear to God, it works fine.
Dr. Park.
Yeah, one thing I'd just like to mention is we've been talking about ophthalmology and iris. And one of the things that is going to give us all power going forward is the fact that we are by no means alone anymore in these issues. When we started, we tried to learn from cardiology, who was really the first specialty out there with an outpatient-based data integrator technology using FIG. And, you know, they were how many years ahead of us in terms of time, Sanket? 3 years? 4 years?
4 years.
4 years. They were 4 years ahead of us. We now have 4 times the database that they do. So that's all thanks to basically all of you, who really have demonstrated a real interest in being able to know what you're doing and move the quality needle. But we were the early adopters. We now have neurology, dermatology, urology, rheumatology, family medicine, psychiatry is getting into it, ENT, who else am I missing?
Oncology?
Oncology.
Emergency physicians.
Emergency medicine. So the point is that when the issues that we were going to Congress with, that we were going to the agencies with as ophthalmology, we're really going to now as a huge portion of medicine. So our ability to leverage this is really increasing. And our ability, we're finding now when we talk to the various EHR vendors, I'm not talking Epic or Cerner here, I'm talking about the next gens and the next techs and the CompuLinks of the world, is 2 years ago, we were kind of blown off by them because we were not on their radar screen. They now recognize that it really is in their best interest to have something that works seamlessly with Iris because, quite frankly, they can market their product better. It's all dollars and cents. And so we are leveraged now to have better input into data fields, our ability now to talk to companies like Zeiss about actually direct input of some of the data that is supposed to be DICOM compatible, like OCT data, visual field data, et cetera, is now increased. So the external game is changing as well as what's happening internally.
So I think that's a good segue to perhaps our closing comments. And that's that this is the first iPhone. There's going to be a lot of development. And Singleton, I'm wondering if you could share with us sort of your vision of where you see this going. Where we had a nice review of where we are today. Where are we going to be in 5 years with this technology?
So I think what we've been able to accomplish, with a lot of support from the AAO and the other specialties at the table, is really demonstrate that data liquidity at a national scale is possible, and that continues to impress various parties that are looking at this, including CMS and ONCs. So so we've been able to demonstrate that what we have to do in the near term and sort of the midterm is to scale and move that number closer to the 200,000 plus on the same platform. I think having this amount of data in a fundamental way that's interoperable also presents a lot of opportunities for collaboration between different specialties in a way that, quite frankly, was never possible before. So there's certainly collaborative opportunities that could, I'm confident will lead to even better opportunities to improve care. When we started doing this, the entire act of data extraction and reporting on it was, again, quarterly. We've taken it down to, reporting monthly. We're doing data extracts nightly, from many participants. I think what this will allow us to do is take the discipline of quality measurement and, going back to your the cereal box analogy. Hopefully, within the next 5 years, we won't be throwing that slide up and pointing to the deficits and transparency as far as what is happening in healthcare. And initiatives like IRIS are, I think, going to be very, very critical. And it's sort of interesting thought. The more we do this, we're actually getting inbounds from HIEs and who are asking that, hey, since you have the data from the physicians, can you send it to the HIE? That's not supposed to be a function of the registry. But what the registries have in effect done have solved the last mile problem, which even the HIEs and the models that have been prescribed by the feds aren't able to solve in an effective manner. The more we do this, the more the dimension, the less this will be called a registry, and the more it will be called a data liquidity platform, analytics platform, what have you. And I think that's where this is headed. We want to be in a position where when you say registries, there's a very set way of thinking about that concept, and I don't think IRIS is a registry. It's a whole lot more than that. And I think we'll be achieving that pivot very soon here.
So to speak to that point, for those of you who had the opportunity to attend Mike Repka's session earlier this morning on public reporting, we heard that from the two consumer advocates. We heard it from the gentleman from Consumer Reports, and we heard it from the U.S. News World Report editor. They want this data. And multiple times the concept of transparency was brought up. The public is demanding this information about their health care. And it's a bit early, but the example that has been given is the Society for Thoracic Surgeons, where you can go now and you can look up and see what their success rate is for a variety of major heart and thoracic procedures. And that's the type of transparency it's simply going to be demanded. Earlier I said that we're the customer for the EHR companies. Well, the patients are our customers, and they're going to demand this information. And now we're going to be in a position to be able to give it to them. And at the end of the day, I think that's going to be a great thing for everybody. Any other questions or comments? Paul.
So we have all this information, and it's granular down to the physician detail, patient detail. Is any of this information subject to subpoena in a malpractice case or any sort of situation like that?
So there's two, obviously the patient medical record is always subject. So are you looking at the quality issues? So in other words, your performance.
Right, exactly. So if you have a physician whose performance may be below the average, and would that be something that could be introduced into court?
So as of today, no. The MACRA statute specifically prevents this type of peer review data. The same concept of the peer review process. That is still not accessible for civil litigation. And I forget what clause it is, but it's in the MACRA Act that it cannot be used. Obviously, could that change? Could a clever lawyer get a federal judge to rule to release that? Sure. But as of today, no. Dr. Park, do you have any closing comments? No. Then I think we are adjourned. Thank you all.